And Dr. Horst, it is yours.
Hi, everybody. There's still plenty of seats in the front, so come forward. It's okay. So this is sort of a personal odyssey, my opinions about various things. Some of it's fact, some of it's about my life and history. It's what Ron asked me to put together. So, and the slides are posted, and you can email me and ask me questions. So, let's see, does this work? Yes, it does. So this is the chronology of AIDS. So I actually first took care of my first HIV patient in 1980, before it was identified. I was intern, began my internship in 1979 in New York City, in the Bronx, and we got a couple of patients with young men with these strange infections. We made the diagnosis. We didn't know, I certainly didn't know enough to know what was going on, why we would treat the infections. I had to order a special drug from the U.S. Centers for Disease Control. This guy, who's now a friend of mine and who's speaking at to our group in June, is named Michael Gottlieb, and he was the guy in L.A. He was in practice by then in Beverly Hills, and he had 5 patients in his practice who came down with this weird illnesses, a manifestation. And so he alerted the U.S. Centers for Disease Control, and that launched the whole thing. And another guy, also a physician, he was actually a dermatologist practicing at NYU in New York, had people with these rare cancers, Kaposi sarcoma. This is just some history here. So this is, do you know who this is? Elizabeth Taylor. So, you know, there's a lot of stars who get involved in, you know, causes and things like that, but a lot of it's just show. They don't really deliver. So Madonna's thing in Malawi is a perfect example. It's just a hole in the ground, nothing of benefit to Malawi. Liz Taylor went door to door, ringing doorbells, raising millions of dollars, reached out, hugged patients, and really helped transform it. These are the 2 guys who first identified the virus in 1983, Robert Gallo and Luc Montagnier. And that's me. And then the first HIV test was in 85, so we could start testing the blood. So what was it like in 1985? There were no drugs. Almost no healthcare workers were willing to take care of these patients. So I had patients would show up at emergency rooms in North Carolina, and the person would come from around the desk and tell them to get out of their emergency room. There were no laboratory tests to monitor the test. You now know about CD4, you know about viral load, drug resistance testing. None of that was available then. There was no easy way even to diagnose the various infections that the patients would get, like pneumocystis. We did not know that once you treated the infections that they developed, you needed to put them chronically on the antibiotics or they would come back. In those early days, we would treat the pneumocystis pneumonia or cryptococcal meningitis or whatever. We'd treat it for a prescribed amount of time and then stop the treatment. And then, of course, since we weren't treating the virus, the infection would come back after a month or 2, and they keep getting repeated in things. There were no good medicines to treat depression. Now, you know, half of America is on an antidepressant. And then there were very primitive antidepressants, and they had lots of side effects. No social service agencies were willing to take care of these patients. So all the traditional things, United Way, the housing folks, Meals on Wheels, the churches, they were running screaming away from this thing. They wanted nothing to do with it. And there was enormous stigma and discrimination. So there was a faculty member here on campus who had hemophilia and was infected with HIV in 1983, and he developed pneumocystis, was in the intensive care unit. I went to see him. His wife was there. His kids were there. He refused to let us treat him. Wouldn't let us treat him. Wanted to die on the ventilator of a treatable pneumonia because it was like too much. He suffered with hemophilia. He was crippled with the joints. He'd gone to think this was the final straw, this highly stigmatizing disease, and he basically didn't want to be treated. I had kids when we developed AZT in 1986. In those days, we thought you had to take it every 4 hours, and people had to wake up at night, and that was the schedule. We didn't realize that the AZT was trapped in the lymphocytes, so that the half-life of the drug in the lymphocytes was 12 hours and longer, and so we could actually dose it once a day or twice a day instead of every 4 hours. In those days, we thought it had to be dosed every 4 hours because that was the extent of our knowledge. We weren't even measuring drug in cells in those days. And so that meant school kids had, and business people and professors had to take it during the day. They wouldn't do it. Kids wouldn't take the drugs unless they would take the first dose early in the morning, and they would take it late at night when they were home, but forget asking to take it to school. So this used to be a huge thing. I used to show this slide set, and the CDC made it. It actually started out where it was a black mat, and each point was a dot, a light of 50 cases, and it would be this incredible thing, but it took so much bandwidth. Why is it automatically going? Uh-oh, this is not good. How can I stop it from there? So anyways, hopefully it won't keep on going like that. Anyways, so it would take too much gigabytes of memory, so because the epidemic was getting worse and worse and worse, and I had to stop using that slide set. So now they make it this way that doesn't take so much memory. But you can see what happened is that it just got worse and worse and worse, and the president who then was, and it started out in the urban areas, and this allowed patients, anyways. So the way the epidemic worked is it allowed people to deceive themselves that they weren't at risk, okay? This was a disease of gay men in New York or Los Angeles or Miami. But instead, of course, it was creeping into all these areas, all right? So it allowed the epidemic to propel itself and continue. So we had this terrible problem, and there's been a history of the Department of Medicine and the School of Medicine that was written, and they sent the chapter out to me. This is going to be a book that no one will ever read. But they sent the chapter. It was written by a couple of folks who I admire greatly in my division. And there was this huge gap. They didn't mention HIV. And because they weren't even delivering the care. And it was just a terrible time. I can't, it's hard for me to tell you how awful it was from 1980 to 1996. For 16 years, every patient I had died. Almost every single patient died. Usually within weeks or months. It was just the worst thing. And this was one of my favorite patients, and he was a volunteer in our clinic. And even though he had one thing after another, he kept volunteering. He would drive other patients to clinic. And finally, it was terrible. And so you can see I wrote, this is the last page, I photographed this, of that. I said I didn't want, the team was too upset about it, the house staff, so I said I'll take it over as his doctor. So I stopped all medications, changed him to IV fluids. I said he's not to be resuscitated, do not resuscitate DNR, and he does not need to be, need respiratory isolation. So they thought he might have TB, so everyone is routinely automatically put, but I knew he didn't, and I didn't want him to have to, his last view be people with masks. So we stopped all that, and then I had the pharmacist write morphine to keep him comfortable, and he died. So it was just a terrible, terrible time. And this is a very upsetting time for me, even all those years later. So let me just... So this is the oath of Maimonides. And it's a very powerful thing as a physician that it's just, one, there's many like it, but it's a very important. For the enemies of truth and philanthropy could easily deceive me and make me forgetful of my lofty aim of doing good to thy children. May I never... Sorry. It's amazing. So I love what I do, but 15 years later, it's still as painful. Grant me the strength, time, and opportunity always to correct what I have acquired, always to extend its domain, for knowledge is immense and the spirit of man. So, you can read. So anyways, the success we got, and many people think of it, it's the pills, and the interesting thing it is, it's public health. Now, I'm not a public health person, I am a physician, but look at what the dramatic impact we've had on the death rate long before we had penicillin. And it was state health departments were created. Municipal use of chlorine in water. All those wonderful women who got educated at the end of the 19th century and the beginning of the 20th century, then went on. There were no jobs for them. They couldn't get jobs, so they founded all these settlement houses in the city, and they got rid of the tenements, and they started helping in clean water and clean sewage. It was just it's a fascinating history of the women's movement, those of you who are interested in, and how the impact they had. The muckraking, journalism is disappearing these days. The muckrake, Sinclair Lewis and everything, writing articles about food processing, tenement housing, no air, factory conditions, etc. All that helped draining swamps to get rid of yellow fever and malaria outside of New Orleans and Philadelphia and Washington. All those had a much dramatic effect than penicillin, and of course then vaccines. So what did we accomplish? Huge amounts of things. So 86, we showed that AZT was affected. The NIH jumped in right away on this and started working on it. The rest of the government didn't. Remember, President Reagan didn't say anything until the last year of his presidency. Meanwhile, thousands of people were getting infected and dying from it. But then look at the power of the legislation. And, there's been so much criticism of what Congress can do, but look at what they did. They passed these very important laws. We showed within 8 years of the first drug, we showed that you could cut off mother-to-child transmission by 2/3. And by 97, and a lot of this work was done here in Chapel Hill, by 97 we had triple drug therapy, and we had the inkling that we now know is true, that people could live a normal lifespan. And there are three heroes in this thing here. Rock Hudson, who really, he knew he was dying, and yet he had, just 2 months before he died, he called a press conference to announce that he was HIV positive. So, and he was this, most of you don't know who Rock Hudson was, but he was this darling of both, turns out, gay men and women who knew, and everybody in America loved him, and before it was some other person that was getting HIV that no one knew. People didn't know who was gay and who wasn't. We didn't even talk about it that much. But Rock Hudson came out and said, I'm gay and I have HIV positive 2 months before he died. Very heroic. It sort of said, oh, God, it's out there. Then Ryan White, this poor kid who, with hemophilia, he was inadvertently outed by the school district in Kokomo, Indiana. All these wonderful, middle-class, good, solid, Americans, they ran him out of town and his family because they didn't want him in the school, couldn't go there. So this kid went on and he became the face, even though he didn't want to be, the face of HIV. And just a brave, brave soul, and that's who the Ryan White bill that funds most of HIV care around the United States is named after. And then Magic Johnson, God love him. So the epidemic was affecting thousands and thousands of African Americans, heterosexuals, and they weren't acknowledging the risk. It was a gay disease, etc. And he came forward and he just bought the Dodgers. So this is, and he showed that yes, I'm a black man I got infected because I was ridiculous in terms of my sexual activities, and I'm still alive now all those years later. Okay, so what did we do? We had this problem, all right? So I set up clinics around the state. That was a job. Having people just to schlep to Chapel Hill for care was ridiculous. So we needed to get experts that were within 60 miles. So we did that. We recruited people. There's a UNC teaching hospital in Wilmington. They set up a clinic. We got Ryan White funding to set up a clinic that's still going in Lumberton. Our teaching hospital at Carolinas Medical Center opened up a clinic. We opened up a clinic in Raleigh at Wake. We took over care of the Department of Corrections in the state. And that's it. And our teaching hospital in Greensboro opened a clinic. So virtually every patient in the state didn't have to travel far. That was an important thing. And then you can see that we had this dramatic impact. So from this absolute horrible time when there was a leading cause of death for men and women, young men and women, it just plummeted, first with prophylaxis for the opportunistic infections, and then with the triple drug therapy. All of a sudden, people really knew it. So certainly we have huge problems, funding, etc., particularly if the Affordable Care Act gets overturned by the Supreme Court. It's a disaster for HIV patients in particular, as well as the rest of us, but things are hopeful for our patients. When I see a new patient, which I did last week, a new guy in clinic, I could tell him, reassure him. I mean, he was just a nervous wreck, and I said, "You're going to outlive me," and which is true. He will. So then in 2000, so that's what I did from 1980 to 2000. I did research, clinical care, what we call implementation of services, so setting up clinics and things like that. And in 2000, I went to the International AIDS Conference, which for the first time, even though the bulk of the epidemic was in Africa, was in Durban. And Ron came with us. We actually presented a poster. That was the first time we presented it, right, on this class. And it got a lot of buzz, and actually published a paper in the American Journal of Public Health about the class and what we were doing, and got a lot of interest from other universities. But this was a powerful meeting, and if I was clever, which maybe next year our IT folks can help me, I would actually show you some videos from the time. Very, very moving. So first of all, there were protesters everywhere, and this is one picture of them, and they want drugs, free drugs for Africa. They had no money. $10,000 for triple therapy was just way beyond when the average amount of money is $1 per day max per capita. Usually it's $1 per capita per year in healthcare expenditures. So, and this was another one. The people want more human medical science. And they had, wonderful singing and dancing, and we all got involved in that. There was this wonderful kid named Nkosi Johnson who'd been born HIV positive. His parents were long dead. He'd been adopted by a white South African. And he spoke. This was at the time when the president of South Africa, Thabo Mbeki, had this absolute blind side to AIDS. He did not want to talk about it. And so Nkosi Johnson spoke to a soccer stadium filled with people attending the meeting, and he addressed the president, this tiny kid, because he was sort of stunted from having the disease from birth. And he was just so brave, and it was wonderful. And he's long since died, but it was lots of heroes around that. So then this is the spread, and shows you how if we had focused on Africa, we might have done something early. One of the problems, of course, is in the early days, the Cold War was going on. So our only interest in Africa was making sure the Soviets didn't gain a stronghold. So the Soviets had their countries, we had our countries, and that was the only thing. And then So we didn't really pay attention to something like HIV. And when you don't pay attention to things, look what happens. The same thing happened in the U.S. and here. And soon you have over 20 to 36% are infected. The interesting thing, of course, about it, HIV is a disease of poor people, by and large. So this just shows you, looking at the U.S., let's not forget the U.S., okay? We still have 55,000 new cases of HIV every year, okay? Been going on now for years. We have not made a dent in it because we basically don't care about the problem in the U.S. We don't fund our public health departments well. We certainly don't care about gay people and gay young people. And so this is just, and women, black women, forget it. We don't care about them either. So then, you know, when that happens, we're going to have this ongoing problem. So for those of you who want to get, everyone wants to go to Africa these days. It's very exotic and nice things like that. You could work in eastern North Carolina. It looks like Africa, for God's sake, okay? They don't have plumbing. They're poor. You know, they're malnutrition, etc. And look at the HIV rate. If you look at census tracts where more than 20% of the household incomes are below the U.S. poverty level, it has as much HIV as some of the countries in Africa. Okay, 3 important things I'm going to teach you first. Africa is not an amorphous blob. Wealthy countries do not play nice, and we have the money to push for change. Now, what do I mean about Africa's not an amorphous blob? So if your Aunt Jane books a safari to South Africa, and there's fighting in Zimbabwe, she cancels her trip to South Africa, okay? These are different countries. The peoples are different. They speak a different language, okay? They have different genetics. They absorb drugs different. They have different strains of HIV. There's malaria in one place. It isn't in the other place. So it's completely different. One of the governments is stable democracy. The other is... So, you know, each of these countries are different, and the interesting thing, you'll go to a meeting, those of you who end up in academics, and sometimes Africans they say the same thing. So you get an African academic and talks about Africa as if it's one blob, and what he's really talking about is his country, Kenya. He doesn't know what the hell's going on in Nigeria. He's never studied there. He's not done research. He doesn't know what the virus is doing there like that. So why does he talk about Kenya and not about Nigeria or Cameroon? So it is a problem. The other thing, so this just shows you some of the difference. So this looks like the gross national product per capita in 1999, and there's a huge difference, okay? So this is Botswana, okay? This is South Africa. The GNP per capita is $730 to $5,000. These are well-to-do countries. Malawi here is under $1 per day. It's poor, okay? The other ones, less so. Nigeria got gobs of oil wealth. Angola has gobs of oil wealth. Okay, the fact is they're not spending it on their people, but they got gobs of wealth. And this is a wonderful, if you look at those TED Talks, you know, this is a great guy who does these moving graphs. It's very cool. So you should look it up, this thing about world development. And this actually is very good. So you have here at the bottom the gross national income per capita, all right, and health indices on here. So deaths in children under 5 years. So obviously this is really bad. Large amount of deaths here, okay, down here, and this is wealth. So you have well-to-do countries here, Equatorial Guinea, who's doing terrible in child mortality. India, terrible in child mortality, given its wealth, okay? You sort of understand this box. You can understand that, where they have low income and low indices. What bothers you is when you've got these countries over here who've got much higher income. They should be doing much, much better than they are. Okay? Transparency International puts out the corruption perception. This talks about these countries. So there's different levels of corruption in these countries as well. Very big issue. So it drives me crazy that in Malawi, the MPs are driving brand new Mercedes-Benz at 100K, 100,000 per pop, when 50% of the kids have chronic malnutrition, so they're stunted. Okay, what is going on here? Or that India is building nuclear bombs when they've got people who don't have clean water. What the hell's wrong with that picture? On the other hand, we're no great shakes either, what we do. And look at this crazy thing. So the EU gives each cow $2 a day. So 1 billion people live on $1 a day, and the total developmental assistance we give globally, all the wealthy countries, is only $50 billion a year. Okay, so our farm subsidies in the EU are $320 billion a year. Stop subsidizing the cows. You know, it's ridiculous. And some of us are generous and some of us aren't. So here's the U.S. about the point. This is the net aid as a percentage of the gross domestic product. We give 0.19. This was in 2008. I actually don't have the update here. The UN target should be 0.7, so we're way below that. But look at, these are the good countries. Sweden, Norway, Denmark. These tiny countries are really kicking ass and doing that. Okay. And somehow we always whine, oh, there's not enough money, not enough money. In 2 weeks, we came up, the EU and Ireland came up with $115 billion for Ireland. And the U.S. Treasury came up with $182 billion just for AIG. And the UK banks came up with $255 billion. This is not talking about Russia or Japan. So somehow the total development aid is $50 billion. We begrudge. We don't even honor our pledges, the countries, for that $50 billion, yet somehow in 2 weeks they came up with over $500 billion, a 2-week period. So those are all issues in the background. Now, what are the key problems? This is sort of my pitch. So these are all the key problems. There's a lack of healthcare workers, lack of a medical record system, lack of clinical laboratories and infrastructure, lack of comprehensive care. So there's a silo method of care, and I'm going to go into what that means. Lack of inadequate supply chains. There's stockouts of medicines and supplies. Lack of coordination among the non-governmental organizations and donors, and lack of the rule of law, the rights of women. Okay, lack of medical personnel. 24% of the disease burden in the world is in Africa. Only 3% of the healthcare workers. 57 countries have a severe shortage, 36 in Africa, and the UN considers if you have less than 220 nurses, doctors, and midwives per 100,000, you're not going to solve the problem. You could do whatever you want. You can give them supplies, pour in money. If you are below that, and this is the WHO target, and you can see these countries, including Malawi, are way, way below that. I did a study, actually never published, which is bad. 40% of the RNs went to the UK at the hospital we work in. So they just left, went to the UK because they're certified as nurses in the Commonwealth system, so they can go anywhere in the Commonwealth, okay, because Malawi's in the Commonwealth. So they went to the UK, they're practicing there, they're earning a decent living, and 13% died of HIV. So big problem. The other problem is it's difficult to allocate scarce personnel with huge fluctuations in malaria and diarrheal disease. So I took this picture when I went into a clinic. Those of you who actually do go overseas and start working, if you want to quickly get data, bring your digital camera or your cell phone and just go into clinics and take pictures of the walls, because everything's on the wall, the graphs, and then you can go home and write your papers and your graphs about it. And I got my first grant this way. And look at this. This is one clinic. So in November, there were 1,800 clinic visits. And then in March, the height of the rainy season, with malaria season and cholera, it was 7,000 visits. So it went up fourfold in patients. But the staff doesn't go up fourfold. So how the hell are they going to take care of that many people with malaria? Okay. This is the medical records system, okay? So the individual patients have these things that look like passports. They're called health passports. The doctor scribbles stuff in. They carry it around with them. It, rubs off. You can't read the writing. It's a disaster. And there's no linkage to their kids unless they hold the kids together with them or their husbands. Men don't carry any one. It's just pregnant women carry one. Children carry one, and sick adults. But if you're healthy, there's no there's no well person care because they don't have the resources. And then you come to clinic and they write the name in those log books from the British they left over from the colonial era, these big log books. The only thing they're useful is, of course, you can total. Oh, we've had 32 pregnant women came, but you can't do any linking. So the mother then goes to labor and delivery, and they have another logbook, and they dutifully write everything in another time. Then she brings her child, a newborn baby, to the under 5 clinic. They write in another logbook. There's no linking. A different ID number for each logbook entry. It's totally useless. The only thing it's good for is totaling the numbers to keep the Ministry of Health happy, USAID, and the UN. You can say, oh, we had 40,000 people with tuberculosis. Not that you know anything about happened to them, or you can close the loop and change things and improve things. Okay, limited laboratory capability and infrastructure. So this is the order form here. Let's see if I can figure it out. Oh, here, yeah. They wanted blood bags so they could draw blood, okay, collect blood for transfusion. They needed 100. They got 20. So this is the stockouts, okay? That's the problem here. Here, this is the guy. This is the lab. He can do gram stains for bacteria or TB smears. That's it. Nothing else. Can't tell you if you're anemic. Can't tell you anything else. This is the roads here. The rainy season, forget it. You can't go through. Mud. All right. This is the hospital. You say, oh, it looks sort of like a hospital. That's laundry hanging over the edge. That's been done by the patient's family. These are family members there sitting. There's no nurses. So it's a family member called a guardian who's giving the care. Housing structure. Obviously, no screens on the window. You're going to get malaria. And this is the silo medicine. So they divide it up, and there's all these separate clinics. But the problem is, pregnant women, 10% of them are getting TB. So you're going to tell the woman, oh, you need to go to the HIV clinic, okay? Pregnant women, once they deliver, they don't want to have babies again. Oh, you have to go to the family planning clinic, which is on another day or another building. So... And there's no linkages again. So I remember when I was in the Congo at one point in Kinshasa, and I went to the TB clinic, and we knew from data that 70% of TB patients in Africa are HIV infected. So we go to the TB clinic, and I asked the head nurse, I said, so are you testing the patients? He said, oh, yeah. How are you doing it? So we send them to the HIV clinic for testing. I said, so, and where's that? And she pointed. It was like across, you could actually see it, not so far away. I said, oh, and then how do you know what happens? He said, well, when we come back. And we asked him, I said, did you go to the HIV clinic? And they say, yes. And I say, and then what do you do? I said, well, I asked them how it went. And they said, fine. So, and that was it. No result, no nothing. So, so a problem with the communication of the clinic. Then more on the stockouts. So this was from another clinic. I took a picture. So look at number of antenatal visits, 1,314. How many got malaria prophylaxis? 0. How many got iron or vaccinations? 0. Nothing, because they didn't have the supplies. So the women dutifully come. 90% of the women will show up at an antenatal clinic, but the supplies won't be there to be able to do anything. Okay. And then poor coordination. This was done by a wonderful medical student who worked for me for a year and now is a pediatric resident at Sinai. And so my program did all the testing of the women, and then we tried to link to others to do the testing. But you'll notice, so there were 15,000 positive women, only half of the infants got tested. This is in the capital. We're not talking bad roads. We're not talking, language barriers. This is in the capital where it should be the best. And only half the infants got tested. And of those, 1,000 were positive, and only 221 ended up in clinic. So out of a potential of, so since half were tested, you can assume that there were 2,000 infected infants. Only 110 out of 2,000 ended up on treatment. Pretty piss poor job. So I always believe you need to publish the bad stuff as well as the good, because this was on my watch, all right? I'm as much to blame for the discoordination about this, and we needed to get this out there so that it gave us a benchmark on what to improve on. The rule of law and the role of women. So you can see here, this is a woman who's dying from cryptococcal meningitis. This is one of my first trips there. May have been the first trip in 2000. This is her sister. This is a health aide, not trained clinician. There are no pain meds, no fluconazole to treat her meningitis, so she's dying. And the house was empty, and water was pouring in the ceiling. So although her husband had died, and they have this thing in many parts of Africa, doesn't matter your class. I know ministers of health who've done the same thing, where if the husband dies, the husband's family goes in and strips the house, takes everything away from the woman. All money, kitchen utensils, leaves her destitute, okay, for her to die a miserable death, okay? That is the role of women. If we could just implement laws that are on the books and empower women, HIV would end tomorrow all over the world. Okay, the way forward. This is from that same first trip. These are coffin shops. This whole street was filled with coffin shops in Malawi, Lilongwe, Malawi. Okay, so a little bit I'm going to talk to you science here. I know this will bring chills through your thing back to the first lecture. Okay, this is when HIV is transmitted from mother to child. About 15% occurs in utero, in the uterus. About 30% occurs during labor and delivery, and then up to another 30% occurs depending on how long the mom breastfeeds. So about half in a mother who's infected, not on treatment, who breastfeeds for 2 years, about half the kids will become infected at some point, okay? So I started working. I'd been there in 2000. I came back in 2001. We got this huge problem. And it's not rocket science, okay? There were 20,000, I figured out there were 20,000 pregnancies in the capital every year. We knew that 25% of the women were HIV positive. That meant there were 1,500 infected babies because about 30% are transmitted early on. Can we solve it? So this is the math. Literally, I did this on a piece of scrap paper, okay? It's going to take, because you have to do informed consent. At the time we did informed consent of these women, it's going to take an hour to explain to them what HIV is, the test, get them to sign the consent, get the blood. So we're going to need an hour per client, okay? That means if there's 20,000, there's about 2,000 hours in a work year. I need to hire 10 nurses to do this. So I did. We need space. Each of those nurses is going to need a room to work in. Clinics were overwhelmed, so we had to build 10 rooms. We built 10 rooms. We need supplies. We need the test kits. We need the nevirapine. We got that. We have to educate the staff, the clients, the government, so they know what we're doing in the community. And we have to do research to know if it's not working well, what's going on and how to improve. So we built this lovely clinic there. There are the women waiting with their babies. And we started the program, so we started testing. So the green are the new attendees, and the pink are the ones who are getting tested. So we started in the second quarter of 2002, and I hired this fabulous woman who took it up, and she's now a physician and working for us. And we had a pretty good uptake, but what happened in those days, we were taking blood, and the women tell them, come back in a week, we'll give you your result. And we got about 35% of the women agreeing to that and coming back. That wasn't good. We wanted 100%. That's the goal. Set a high bar. So when I would come home from elementary school and I would have an A-, my mother, who was a Polish Jew, Holocaust survivor, she'd squint at the minus and she'd say, as if it was like a dead cockroach, and she said, "What happened?" So you gotta set high bars. Set high bars. You don't want 80% success. You want 100% success. Okay, so it wasn't good. So there were these rapid tests. You take just a pinprick of blood, you put it on this little plastic wick with paper on it, you put a drop of chemicals on it, solution on it, and voila, it turns a little blue line or not, and you know that the mother's infected, okay? Do it right then in 10 minutes. She gets to see it. When they see it, they believe it, absolutely. Otherwise, you get this disbelief. So we instituted same-day rapid testing, and voila, we got up to 85%. Was I happy? No. Wasn't 100%. And the problem was the women weren't agreeing. About 15% were too scared of what their husbands would say. So I was flying over, and I opened the New York Times. The front page was the Festus Mugai, the president of Botswana, was quoted as saying, "The Western model of informed consent is not working in Botswana. I have all this," because Botswana has tons of money. "I have empty clinics and dying population." Okay? We got to change things. I'm writing a presidential executive order. Everybody who goes for any reason to a medical person or a dentist is getting an HIV test, starting with me. Stigma was gone. Okay? Just happened. So I said to the government, let us try opt-out testing. You tell the women, you're pregnant. This is what we're going to do for you. We're going to check you for HIV, syphilis, your blood pressure, make sure you're not anemic. Is there anything you don't want us to do? If they say, well, I don't want the HIV test, fine, they don't have to have it. If they say, they don't say anything, they get tested, no written consent, and we all of a sudden went to 99% uptake. And what happened is that this was not being done in a city the same size, and we had this, they didn't have any decrease in women having HIV, but in Lilongwe, when we started out at about 25%, we're now down to actually 11% of the women in the antenatal clinic pregnant. So it's dropped by more than 50%. And now we've set up a program to expand this to the 5 districts around it, 153,000 pregnancies. So what are the issues on there? And I'm going to race through this here. I know we're running a little behind. So this is the problem. Again, I started out in Lilongwe at 2001. What's the problem? How do we address it? How do we improve it? Now what's the problem wider in the country? Same issues, okay? So less than 10% of the HIV-positive pregnant women who's had low CD4 counts were receiving medicines. So that meant 2,000 infants were getting infected unnecessarily. 0% of the women with high CD4 were getting medicines. That meant another 1,500. So you're talking 3,500 infants infected every year, which is completely preventable. Okay? Less than 1% of those infected infants were receiving any treatment, so that meant 1,600 deaths. And of the adults, 51,000 were in need of treatment every year, and they weren't getting. And those on treatment weren't staying on treatment, less than 50%. And 9% were dying the first 3 months. The TB case detection rate is 42% only. Terrible. So all these people are getting TB, and we're not diagnosing it. And the treatment success for the TB is only 73%. And reproductive health, a quarter of the women weren't getting any access to family planning, and none of them, less than half, were getting access to modern methods like IUDs, etc. And a huge maternal mortality. And then the kids were dying as well at a huge rate, 163 per 1,000 live births, or 25,000 children were dying in these 5 districts. 50% were malnourished, none of them were sleeping under mosquito nets, and none of them received rehydration salts for diarrhea. So Lao Tzu said, a journey of 1,000 li begins with the first step. That's all it takes, one step. UNC is working all over the place. Educating community, there's me when I had a beard, dancing, educating these women here about the program so they understand it, going out to the village. We need to increase the number of medical personnel, so we make the schools bigger. South-to-South training, rather than sending them to the U.S. to train, send them to South Africa for training. We need to boost their salaries. We need to test the healthcare workers and treat them. We need to increase productivity by eliminating the silo system, putting an electronic medical record and incentives. We need to pay.
You can slow down.
Okay.
You've got, it's okay, the clock's wrong back there.
Oh, it's wrong. Oh, I'm sorry. Okay.
Yeah,
All right.
it's
Sorry.
20 after.
Okay.
You've got
Sorry.
about a half hour.
Okay. Sorry. Wealthy countries need to pay a bounty to countries that train their healthcare personnel. So if you go into Chapel Hill and you see a nurse from Kenya, ask the hospital director, did the UNC hospitals send a check to Kenya for 50 grand to pay for this woman's education? Because that's what we should be putting back into their health. Now, the Brits have started doing that, okay? Because they've started doing this thing, at least in Malawi, I don't know. But the US and Canada haven't been doing it. We need to task shift from the nurses to others, okay? What I mean is that you don't have to have nurses filling out ledgers, okay? You don't have to have nurses even doing HIV tests. You can get a volunteer to do a pinprick and do it. Leave the nurses to put in IUDs, to do minor surgical procedures, to put in Norplant, the year-long contraceptive under the skin that we use. Use volunteers, traditional healers, village committees, and don't train during the work week. Those of you who are in public health, all these non-governmental organizations, they want to do training of all these people. Well, if you're training them during the work week and you've got 25% of the staff you need, that means you're taking these precious staff away from their clinic. And there's no, the patients in the villages can't go on Google and to see if the clinic's open. So they pay their precious kwacha to the minibus driver or walk 10 kilometers to get to the clinic, only to find that, whoa, the nurse is being trained by UNC or UNICEF or Save the Children or something like that. And why do the nurses do it? Because they get a per diem, okay? They get $40 for their day, which is 10 times their salary. So you could live a cushy life on just the training that we Western and wealthy countries are doing there. So training Saturday and Sunday, only time should be. That's Charlie's rule. Okay, South-to-South training. So Dan America, Agnes Moses, two really, really smart. UNC, there's a great medical school in Malawi, but no residency program. So we sent them to South Africa. They're the first internists, Malawian internists, back in the country who are practicing medicine. Instead of having, they have these expatriate doctors from Germany and France running a hospital ward. They don't speak the language. The nurses don't listen to them. Charnel House. When these two get in there, all of a sudden things start working together because they don't put up with any crap. Get the traditional birth attendants. So my idea was that 50% of the women were delivering at home with the traditional birth attendants, often grandmothers, etc. They pay a small fee. But they're illiterate. So can we give birthing kits to these women? All you need is a match to sterilize a blade, right? A match and a candle to look at, sterilizes the blade, plastic sheet to put under the woman so the baby doesn't drop off in the dirt, a piece of string to tie off the umbilical cord, and you're all set in the razor blade, clean razor blade. But you want to give them a log so that they can record it so you know what the hell's happening. And so this is the log. My staff came up with this, little pictures. Introduce an electronic medical record system. Now this, you're probably going to say, come on, mud roads, thatched roof, are you crazy? Anybody who wants a cold Coca-Cola or beer in Malawi, no matter how remote, can get it. So clearly there is some electricity, all right? they were way ahead of us, the Europeans and Africans, in terms of cell phones than we were just a few years ago. They were a lot of people have it. So they won't have a phone booth, like a standard phone booth. There'll be a little, tent-like plastic structure with someone sitting there, the doctor is in, with a cell phone. And you pay a few kwacha to her or him, and they hand you the phone, and you call someone. That's the phone booth. And then they just cart off their little phone booth at the end of the day and come back. So, it's very clever entrepreneurial. So if you can do all that, you can do an electronic medical record, okay? And these are this very clever, there's a pediatrician at Harvard named Mark Mitchell, I think is his name. And he started he's at this Harvard School of Public Health, and he started a nonprofit called D-Tree, letter D-Tree, and they're doing this kind of stuff. And so I'm helping him because his was a little open-ended. He wasn't closing the loop. He was putting information in, but they weren't using it as much. But this is on a smartphone, a $100 smartphone that in Malawi that you can do this. So you put in drop-down menus, just check thing, pale, not pale, etc. You can put this in and look at it. What I want him to do is to put that information from that cell phone into the cloud, and then when the woman goes to labor and delivery, the nurse there can scan in her barcode and get the same record from the cloud and say, oh, she's already been tested for HIV. I don't need to test her again. Or she's really anemic, or she had stillbirth previously, so she's at high risk. Point of care testing, what that means is rather than taking the blood and sending it away to a central lab, you need to do new technology. And these are engineers and chemists that come up with it. And this is a friend of mine at Cambridge University in the UK, Helen Lee. So this is a strip of paper, and all magic stuff happens to it, and it tells you that not only this doesn't measure antibody, this is measuring the actual virus, okay? So this is telling you how much HIV this woman has, how much hepatitis C, and how much hepatitis B this person has, okay? And then you can diagnose these babies early rather than waiting late. Okay, So comprehensive care. So what I want is a checklist. So someone comes to the health clinic and the volunteer has a checklist. Okay, have you been HIV tested? Oh, no? Here, let me test you right now. Are you on a contraceptive? Okay. Then no, here, can I give you I can give you a Depo-Provera shot myself, or I can schedule you for the nurse to give you an IUD or insert Norplant. You have kids at home, how many kids? Oh, you have 2 kids? Here are 2 insecticide-treated nets for them so they can sleep under. This is how you use them. Have you had a fever, a cough, weight loss, or night sweats for 2 weeks or longer? Oh, that means you might have TB. Let's get a sputum sample so we can look for it, etc., etc. It's not rocket science. Each of these things are cheap, okay, to implement, and we know how to do. We just need to do it. Stockouts is a huge issue, and I actually don't know. Is it theft, incompetence, lack of donor funds? We need to explore why it is. We need to identify clinics and labs where they don't have stockouts. What are they doing different? And implement an electronic medical record system. We need to improve coordination. There has to be monthly meetings of the stakeholders, the Ministry of Health, US, the Brits, the Germans, Save the Children, etc. We need to incorporate the Ministry of Health people into the leadership of these new programs. I want to offer incentives. It's been blocked so far. You get a clinic, I've got 130 clinics, I think, so divide them up into groups of 10 and say, okay, if you guys, these are the targets, whoever meets the targets gets $1,000. You can spend it in the clinic, not on yourself personally, but anything will buy refrigerators for all your clinics or something like that. And the electronic medical record system would improve coordination. Empower women. There's been lots of evidence about this. If you allow women to save money or you give them a job, all of a sudden fertility rates drop down, health of the family improves. If you give men the money, they spend it on booze and sex, okay? Not much difference from the U.S., right? So, but anyway, so you need to give, these women will earn a few kwacha. Where are they going to put it? There's no banks, okay? So they need to get small loans so they can start their little business, okay? They can buy seed, maybe buy a little small plot of land to give them some independence so they can determine what is going to happen to them, all right? Better contraceptive technology that they control. Condoms, you got to get the man to do it, whereas IUDs, microbicides to kill HIV, and UNC was very involved. Angela Kashuba in our pharmacy school was one of the leaders in developing drugs that have been shown to actually work in a microbicide, a vaginal microbicide that kills all these viruses to prevent infection. And better emergency care for transplant. Huge problem. Jeff Wilkinson, who's on our faculty in obstetrics and gynecology, is living in Malawi with his family and his 3 kids, and they are trying to tackle that issue. It's useful for you to look at the Millennium Development Goals. These are made by the UN. They're actually quite good. Okay, they start out broad, but they actually have targets for what each of these countries should do, and you know they're sort of yeah, we need to do this, and it's good to have goals and target, and you can hold countries accountable. Okay, what makes me angry? The word sustainability. If you talk to a lot of government agencies, they say, well, you can't start that because it's not sustainable. Okay. What about the Girl Scouts? If we didn't buy every year, would the Girl Scouts be here next year? No, they'd be gone. Okay. They're not sustainable. But we don't. We buy the cookies. So why do we say? The other thing is, if you talk to a woman. When I was going to start out with my program, my prevention mother-to-child transmission program in Malawi, and people said, well, you can't start it. You don't know. You only have a grant for 3 years. So I said, okay, well, let's ask the mothers. Okay, so I have this program that's going for 3 years that may keep your baby from getting HIV, but I don't know what's going to happen in 3 years. Do you want the pill or not? What is she going to say? Give me the damn pill. So sustainability is a ridiculous concept, okay? You need to think about it. We don't do bone marrow transplants in Malawi. But these other things, if we've got funding now, will make it work for cheap things to implement. Training, you already heard my talks about training. Now, palliative care, those of you who are nursing students or nurses might get upset at this because that's a big thing. Palliative care is good if you have care. Okay, so if you have drugs to treat cancer or AIDS or malaria, so palliative means that you basically you've exhausted all treatments for cancer or for AIDS, and you keep the patient comfortable and make sure their symptoms and they die a dignified death. And I certainly believe it. I used it for both of my parents. It's great. The problem is putting resources into palliative care in Malawi when we don't have cancer chemotherapy drugs, or we're only treating 50% of the people who need HIV treatment, is a waste of money. I don't want to ship morphine over there when I'd much rather have AZT. Okay, needs assessment. We know what the problems are. Okay, we don't have to go in and figure out what the problem is over and over again, but the government always wants us to do it. Social marketing. If you charge them for it, they will value it more. Now, this used to be a concept that was big in the early days of tuberculosis when they got the first medications, okay? They said, well, we can't give the medications for free, even though TB was a big issue in the early 50s and late 40s in the U.S., because they won't value it and they won't take it, okay? That was the thinking, all right? So we said, we'll charge it. But then TB just kept going up and up. And then they did studies and showed, no, if you give it, they'll take it if you tell them what's it for. Similarly, if you say to the mother, you have to pay $1 or 160 kwacha for this insecticide-treated net, it is going to prevent your child from getting malaria sometime in the next 5 years. And she's thinking, I don't have money for maize today for my child who's going to die tomorrow if I don't give him it. It's not a difficult decision. So I don't like social marketing. The neo-colonialism of the non-governmental organizations. So it is good. Our people living over there, I don't want you to get me wrong, it is difficult. It's not easy. They have, particularly the ones with young children, their kids are very high risk of malaria, which is bad. There's no medical care there, decent. You have to be We've had 2 major life flights to South Africa from Malawi of employees. One, a faculty member, nearly died. So it's a big deal. On the other hand, they're being paid Western salaries, okay, driving big cars that they don't have to pay for, housing they don't have to pay for. They got cooks, gardeners, guard, and a nanny if they got kids. So it's a nice life, okay, as well, particularly if you're in the capital of these cities, okay. So I think, and some of these folks, both, and not just from the U.S., if they actually solve the problem and would have to come home, it would be a terrible thing. So God forbid they should organize and follow some of the things I said so they could solve the problems here. And then experts who aren't experts. So the Clinton Foundation was really bad. They would hire these 24-year-olds, send them over there. They were rude to the Malawians and the Kenyans and the Nigerians. They knew nothing and didn't realize they knew nothing, and it was just really offensive. And that's it. So I'm very well funded, thankfully. I keep writing grants and projects, and people give me the money. It's nice. This is my crew a few years ago in Malawi. That's the leader of the Long Way Problem, Francis Martinson. He's an obstetrician. And this is our community advisory board there. A ton of people. I'm just a figurehead. A ton of people, and that's Lake Malawi. Most important, vote. Ramshead Dining Hall, 2nd floor. All of you who live in Orange County, go vote tomorrow. If you're not registered, just bring anything that has your current Orange County accurate address, and they will register you and let you vote then, okay? So please vote in the primary. You can do it this week, Saturday in the morning, next week, all day, Saturday in the morning. You can't register on voting day. Okay?